for. This is survival analysis. Survival analysis is a method of analyzing data when the response of interest is in time until some event occurs. This time to event could be lots of different things in optometry. It could be a time of death from cancer, or time from the first diagnosis. It could be time to recurrence of or relapse of a disease. It can be time to a disappearance or occurrence of a disease. Time to loss of vision is pretty common, especially from things like diabetes, macular degeneration. Or it could be time to occurrence of changes of soft tissue after contact lens wear. Time to keep your eye. Before intravenous chemotherapy, few eyes with retinoblastoma survived. Retinoblastoma is a type of cancer that young children between the ages of 1 and 5 typically get. There's lots of different stages which you'll get into later in your curriculum. But this study looked at people in Group D. Group D people were a pretty late stage disease, and that was defined by largely or poorly defined tumors with widespread vitreous or subretinal seeding, and the retinal may become detached from this actual growth of the tumor. We've got a picture up here of actually a retinoblastoma in the upper left-hand corner for me. And what they did is they used survival analysis using what's called a Kaplan-Meier curve, which we'll get into later on, to look at the respective survival rates of that eye following treatment over the corresponding 10 to 15 years. And that's what this plot down here in the lower right is showing is over time, if you were in that Group D, you had a decreased rate of that eye surviving, where you're keeping that eye over time. Starting at year 1, you're around 85% and going down to about 50% of people kept their eye at 10 years. Kaplan-Meier estimates of globe salvage, here's the closer picture of that, where 63% of the eyes were salvaged at a median follow-up time of about 55 months. But you can also do that to compare two different treatment modalities or two different conditions. Here's an example where that same data is looking at early treatment failure. So if they tried to treat the retinoblastoma but failed, you had a much worse result than if you actually went with the chemotherapy. You could keep your eyes for up to maybe 10 to 12 years longer. So there's a survival analysis and event analysis. Event analysis is really just the inverse of survival analysis. That's what's being shown here. Is we can look at two different treatments for, say, diabetes. We don't really do this anymore, but old-time treatments of diabetes using laser treatment, you could see the difference between those two different types of lasers. Here's an image. Here's a study that we're going to get into a little later on. You could also do that to compare two different treatments from drugs. This is a glaucoma trial where they used brimonidine and timolol, and what they were looking for is what percentage of the population developed field progression over time. What you see here, if you're looking without actually analyzing the data very closely, is brimonidine went much longer without any development of visual field defects compared to a timolol group. So if you were just looking at this as a casual optometrist, you might think, I should definitely put my patients on brimonidine over timolol. Again, we'll go into a little more detail about that here in just a little bit. So let's look at some definitions. The probability of remaining alive or not going blind for a specific length of time. The probability of not having an event, i.e. progression of myopia, progression of glaucoma over a specific length of time. That's the survival definition. Survival is not having an event. Event is the endpoint at which our findings are observed. Examples of endpoints are blindness, death, torn contacts, onset of symptoms, development of corneal ulcers. Here's another survival analysis looking at corneal infiltrates. Essentially, if you're wearing silicone hydrogel contact lenses, what was your risk factor for developing a type of infiltrate or a white blood cells buildup in your cornea after constant wear? And what that was defined by is those people with higher bioburden, that means dirtier lenses, another way to think about it. Those with high levels of buildup of dirty lenses rapidly progressed to corneal infiltrates much faster than those groups that had no buildup of deposits on their lenses. There's a lot of problems, though, that can occur with survival analysis. One of those events is one must wait for all the subjects to die or have that event. Another is all subjects need to be observed for the same amount of time. And so another terms we think about is interval, the set time of period, most often months or years that we examine somebody. Withdrawals, those are patients that are lost to follow-up or entered studies too late to be analyzed over the desired interval. And following censored, Subjects who are still living or have not been observed at the event at the end of the interval. These are called censored observations or right censored. Here's two different study examples of why those events might happen. On the upper blue lines, we have a set of patients who all started at different times. On below, we have the same length of time of those studies, of those subjects, but they all started at the same time. If you analyze these incorrectly, what you'll discover is that the blue line, where you didn't start at the right times, actually has a much longer survival rate than if you did it the proper way, which is the red line. In the red line, when we all started at the same times, there actually is a much quicker drop-off in time, in this case months, for whatever the study was. It could be, again, development of visual field defects. It could be to development of corneal ulcers, whatever you're analyzing over time. The second thing to look at in this plot is that we have two subjects in each group that make it to the end of the study. Those are censored subjects that shouldn't probably be analyzed because we don't know when the event is going to occur for them. They could survive and outlive the whole study and never have that event, but we can't really say for sure how much longer after that 40-month period they would be safe in this situation. Some other problems with dropouts and censoring. In some studies, many subjects drop out before the end of the study. A high dropout rate gives greater weight to the events that occur later in the study period because the number still in the study has decreased. An example of that would be starting with 13 people, one has an event, so the mortality rate is 1 over 13 or 8% over the first time period. By the next event, though, 4 people have dropped out. We have no idea what happened to them. They could be alive, they could be dead, they could have had some other events, who knows. But the reality is, once as you do that, your mortality rate is now 1 over 8, even though you've lost no more people to the actual event. We're at now 13%, which is an increase that is unjustified because you had a high dropout rate. Some other assumptions of survival analysis. Experience of the person after withdrawal is the same as those remaining under observation. Pooling relates to individuals with similar risk within the interval of analysis. Withdrawals occur uniformly within an interval, and the risk is constant within an interval, which is not always the case in all these analyses. Let's go back to our brimonidine timolol example. Again, just looking at that at base level, you would think that brimonidine is the preferred treatment. It results in less visual field defects over time, over the 4-year period of the study. But what they don't tell you is brimonidine actually makes your eyes sting quite a bit. It's really irritating. A lot of people don't want to take it. So what happens is a lot of the subjects actually dropped out of the brimonidine's trial before you actually got there, as we can see down here. Now, any study of these has to show you these if it's going to be a valid study, and this is typically required nowadays for this very reason. If you look at the number of inactive subjects, a lot more subjects dropped out of the brimonidine group just purely because they couldn't tolerate the drop, which affects the results and makes them really uninterpretable and not valid to measure the difference between a brimonidine group and timolol group when almost twice as many subjects drops out. Thank you.